Hello, everyone, and welcome to today's live broadcast. One academic medical center's experience with the Unyvero Multiplex platform for testing bronchoalveolar lavage fluids, analytical and clinical assessment. I'm Alexis Krause of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by OpGen, a precision medicine company harnessing the power of molecular diagnostics and bioinformatics to help combat life-threatening infectious diseases and fight antimicrobial resistance to improve patient care. For more information about our sponsor, please visit their website at opgen.com. So let's get started. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. If you have trouble seeing or hearing the presentation, report your problem by clicking on the Ask a Question box located on the far left of your screen. This webinar is educational and thus offers free continuing education credits. Please click on the Continuing Education window at the bottom of your screen to obtain your credits. I'd like to now introduce our presenters for today. Dr. Snyder, Director of Microbiology and Infectious Disease Molecular Diagnostics at the University of Louisville Hospital in Louisville, Kentucky, and Dr. Wes Hoffmann, Infectious Diseases Pharmacist at the University of Louisville Jewish Hospital in Louisville, Kentucky. For a complete biography on our presenters, please visit the Biography tab at the top of your screen. Dr. Snyder, welcome, sir. You may now begin your presentation.
Thank you for that introduction. I'm Jim Snyder, and I'd also like to thank OpGen for the invitation to participate in this webinar today, as well as LabRoots for facilitating the presentation. We will be talking about our experience here at the University of Louisville with the Unyvero Multiplex panel for testing for lower respiratory tract pathogens, specifically in bronchoalveolar lavage fluids. I will be discussing the technical or the microbiological aspects, and my colleague, Dr. Wes Hoffmann, will be discussing the antimicrobial stewardship and clinical impact based upon the data that was generated from this study. As you can see, the title is a little different than the full title representing the entire conference, but we specifically are going to be focusing on the conventional microbiology culture and detection of resistant gene markers, in which we are comparing the Unyvero lower respiratory tract system to our current standard of practice in our laboratory. So our conflict of interest. As everyone knows, we are currently, and will be for some time, in an era of rapid diagnostics. So I want to really explain, and by way of objectives, our experience with the OpGen Unyvero lower respiratory tract multiplex system. And I'll begin in a few moments with a little overview of the operation of the system, discuss our study protocol, and then we will discuss the analytical performance of the system, which is, as you know, a direct system for testing, in our case, BALs, and share with you the data regarding our results compared to conventional culture, including identification, which is done by MALDI-TOF in our situation, and antimicrobial susceptibility testing as it relates to the detection of antibiotic-resistant markers, which is part of the Unyvero system. This is an overview of the instrumentation itself. As you can see, it is a PCR-based instrument with an array detection with high multiplexing capability. is a closed system based upon the use of a cartridge, barcoding, and so forth. Another feature is this random access, and it's a benchtop instrument. It doesn't require a lot of space, very convenient, provides qualitative results using an algorithmic-based approach in the computer-assisted system. And the idea is to generate actionable results, obviously rapid in nature, to promote and influence antibiotic stewardship and overall patient management. You can see here the lysator. This is the control center, which they call the cockpit, and then the analyzer. And being random access, that means you can run more than one specimen at a time. We were running 4 at a time during our study. Once again, this is the compact unit that was a benchtop, and we had it in our research laboratory. The principle of the operation of the system is relatively simple. As you can see here, this is the main test cartridge. Once again, I emphasize it's a closed system. And in this cartridge, the events listed here take place where the specimen is initially lysed, followed by extraction of DNA, process for PCR testing, and the array hybridization is related to the targets that I will show you here in a moment. And the turnaround time for the test is approximately 4 to 5 hours. This is the summary of the targets. As you can see here, there's approximately 30 targets. All of these bacteria, including the fungus pneumocystis, is definitely or are definitely associated with and cause pneumonia. Mycoplasma is also included, which, as most of you know, is a very difficult organism to grow. And sometimes you can even miss it on the subsurface of a blood agar plate, but they will grow in culture. Usually, in my experience, it's been 2, sometimes 3 days. But once again, it's the observation that makes it difficult. So these are the targets that are detected in the system itself. Another part of the assay is the detection of resistance genes, genes that are associated with carbapenem antibiotic resistant, genes, CTXM specifically for the 3rd generation cephalosporins, specifically ESBLs, and the MEK-A gene, which is responsible for resistance to oxacillin and or cefoxidin or both, and then the TEM gene, which codes for the enzyme penicillinase, rendering the organism resistant to penicillin. So these are the panels in which the resistant genes, and you can see there are a plethora of the carbapenem genes beginning with KPC and ranging through the OXs, the NBMs, and the BIMs. So quite a bit of information generated in that 4 to 5 hour time. So total of 19 bacteria, 1 fungus, and then the 10 resistance markers. This is the workflow that we followed in our laboratory. Essentially, the evaluation was restricted to bronchoalveolar lavages, which were our primary and really only specimen. And of course, it was cultured in our standard procedures. And we did quantitative cultures of the BAL. And our threshold is less than 10,000. If they were less than 10,000, did not warrant full workup, that is, a full identification and susceptibility. The threshold making it eligible for full workup was greater than 10,000 colony forming units per mil, and that included then a full ID of the pathogen using the multi-top and then our antimicrobial susceptibility testing. If it was less than 10,000, there was no further workup. It all began with a gram stain. We monitored for the quality of the BAL. And specifically, we knew we had a BAL if we saw columnar epithelial cells. We were looking for, of course, like you would in any gram stain, evidence of inflammation in the form of WBCs, and of course, characterizing the morphotypes, such as gram-positive cocci clusters would be morphologically suggestive of Staphylococcus. Gram-negative short plump mirage would be morphologically suggestive of Enterix. So the gram stain, as most of you know, is the most rapid, the cheapest, the most informative, and the most abused test in the clinical microbiology laboratory, but it is really where it all begins when it comes to assessing quality and getting some idea of what you might be dealing with in that specimen, because cultures are going to be available within the next 24 to 48 hours. With the Unyvero system, the BAL, residual BAL, was introduced into the lysator and eventually the test cartridge, and within 3 to 5 hours, the assay was complete. In our particular setting, we decided to issue a preliminary report to selected individuals, and specifically, we notified the provider and the PharmD. In this case, it was Dr. Wes Hoffmann, for any possible action that they would want to take when the results were made available to them. And I'll say more about that in our protocol. Once again, to emphasize, we restricted our testing to BALs only. Our target was 60 specimens, and our inclusion criteria included residual BAL specimens received for quantitative bacterial culture, patients who were eligible were in ICU only. They had to be greater than 18 years of age and met the clinical suspicion of bacterial pneumonia. And by the physician selectivity, they decided if this patient was suitable to be entered into the study. Specifically, the candidates or the patients for studies were selected by either an infectious disease physician or by three pulmonary physicians. So these were the only individuals that were permitted to order the test. And once again, we had to have more than 1 ml of residual BAL that was either fresh or refrigerated to be eligible for testing. I should indicate we had IRB approval to conduct testing. Once the BAL was received in the laboratory, the processing individuals had to check for its eligibility, beginning with the provider's name. We had a list of those providers that were eligible to order the test, and if their name was on the ordering form electronically, that BAL was set aside after culture for Unyvero testing. And depending on the time of day, we either tested them fresh, and I will say that the majority of them were refrigerated for at least 12 hours before testing throughout the night, so to speak. The exclusion criteria, we were not going to test any non-hospitalized patients, so I will admit that 2 outpatients who had bronchoscopies slipped through the cracks, and we included those in on our bacterial data, but not in the antimicrobial stewardship and clinical impact on patient management. Obviously, patients who were not suspected of having bacterial pneumonia as determined by the eligible ordering physicians were not included. And it was very, very important. Pediatrics were excluded. Cystic fibrosis patients were excluded. And if we had less than 1 ml of residual specimen, that was not considered eligible for testing. So that overview is our protocol. And what we did was, with the results with the Unyvero, I either called the provider immediately with the results, or at the same time, I called the PharmD, Dr. Wes Hoffmann. So two individuals usually knew the results shortly after the Unyvero results were recorded. So getting into some of our data regarding the bacterial targets, as you can see here in this bar graph, the yellow representing culture, the blue representing the Unyvero, and we had a total actually of 62 specimens. The total negatives, that is negative by both Unyvero and culture, was 37. So when we said negative specimens, we indicated it was either no growth or it was below the 10,000 colony forming units by quantitative culture, and we've classified them as indigenous oral flora. And we wanted to look at, of course, concordance for the organism targets. But before I get into that, just to show you the organisms that were detected by either culture or Unyvero or both. And as you can see here, more were detected by Unyvero than culture for Staph aureus. 4 out of 4, both for Pseudomonas aeruginosa. Unyvero, in this case, detected 2 additional E. coli for a total of 4. 1 by culture, 3 by Unyvero, and so forth with regards to the remaining organisms. So once again, you may say, well, the database is small, but we decided statistically that we needed a minimum of 60 specimens to accurately assess the performance of the technology. So this ended up to be that there was concordance for organisms, those targeted organisms with a little over 99%, with positive agreement rate for resistance genes being 90%. Once again, this is all compared to bacterial culture and phenotypic susceptibility testing. So there was good agreement with the Unyvero somewhat overall outperforming culture, which wasn't a surprise to me, but at the same time, it's the assessment of the culture and the quantitation that determine what gets worked up and what did not. This is a rather busy slide, but it goes to show you for each of the targets that are in the system, 26 positive total, which were detected by the Unyvero versus 20 targets detected by culture. And I want to stress there were off-panel organisms that were detected by culture that are not part of the Unyvero target panel. These included 1 Achromobacter xylose oxidans, 1 Agrobacter cygnus, there was an Enterococcus faecium, 1, Group B Streptococcus, but these are not commonly regarded as agents of pneumonia. So not being in the database, but recovered in culture, on lab rounds, the recommendation was these are not pulmonary pathogens, even though they were identified. We indicated it was a learning opportunity for some of our technologists, especially our younger ones, that these organisms are not considered pulmonary pathogens and really did not need to be fully identified, and et cetera. Yeah, there could be clinical extenuating circumstances, but once again, when you see the Unyvero results, many of these either had no detection by Unyvero, but were detected as organisms in culture. Once again, not commonly regarded as pulmonary pathogens. So if we look at discordance by sample, I thought that was a very interesting finding. You can see here that Group B Streptococcus was recovered in culture, but actually in the Unyvero detected Haemophilus influenzae. And we know that Haemophilus influenzae is a significant cause of pneumonia. In this particular case, culture yielded both E. coli and Enterococcus faecium. Well, once again, the E. coli was detected by the Unyvero. E. faecium is not in the targeted base, and I'm not aware that E. faecium causes pneumonia. I regard Enterococcus in most cases as a tag-along organism, except in certain circumstances, such as bacteremia, urinary tract infections, and etc. Now, here we have both agreement with Staph aureus, but this Staph aureus in culture was not worked up because it was less than 10,000, most likely represented colonization. But it was detected in the Unyvero, it was reported, and it turned out to be methicillin resistance by virtue of the MECA gene being detected. So once again, one could argue that maybe this Staph aureus in culture should have been worked up, but the policy is if it's less than 10,000, it is not eligible for full workup based upon what we know from the literature and the quantitation of BALs. We had several reports that indicated indigenous oral flora. Well, Staph aureus, which was detected in the Unyvero, whether or not it was clinically significant, only the clinician can decide. But Staph aureus can be a colonizer, and it can also represent a carrier state. But once again, we refer to this as indigenous oral flora. Similar situation in the next group here, where we had indigenous oral flora reported by culture, but the Unyvero detected E. coli and Staph aureus. Once again, having been associated with pulmonary disease, pneumonia, whether or not they were clinically relevant is a clinical decision that had to be made by the pulmonologist or the infectious disease physician. Then the Enterobacter cloacae complex, detected once again by the Unyvero, in addition to culture yielding Klebsiella oxytoca, which was also detected by the Unyvero. But you'll notice the Unyvero also targeted and detected Klebsiella pneumoniae and Citrobacter furundae. All four of these can be associated with pneumonia. Once again, we are dealing with a genomic-based system in which we are detecting these respective organisms, and what their clinical significance is the responsibility of the clinician, but we're obligated to report them. There was the Chromobacter xylus oxidam, which I referred to in the previous slide. Obviously, it's not in the database or the target base of the Unyvero. Here we have a Staph aureus. Once again, Proteus, although regarded as a pulmonary pathogen, was less than 10,000 colony-forming units. It was not fully worked up. So Proteus was identified based upon its cultural characteristics, namely spreading and etc. But we did detect in the Unyvero the Staph aureus. Now, I should advise you that the testing was done independently. The individual conducting the test on the Unyvero was blinded to the results of culture. All these specimens were de-identified before the individual performing the testing received them. So he had no knowledge of what was being found in culture. So in this particular case, we have a Staph aureus, also detected by Unyvero, and once again, with the Proteus, there'd be no microorganisms detected. In other words, it was not detected in that particular specimen, even though Staph aureus was there. Another situation of indigenous oral flora, in this particular case, Streptococcus pneumoniae was detected. And everyone knows the Strep pneumoniae is a pathogen that is responsible for pneumonia. Here we had a situation where Pseudomonas was detected by both culture and Unyvero, but you'll note that the culture reported out resistant to cefepime and aztreonam. Pseudomonas aeruginosa, no resistance detected in the Unyvero. That's because there aren't any gene targets for the AMP-C, which is likely responsible for the resistance that we saw in the cultural form of the Pseudomonas aeruginosa. And then another way of reporting oral flora, we've reported in this case mixed oral flora. The Unyvero happened to detect E. coli. Once again, a pulmonary pathogen. Whether or not it was clinically relevant, that would be the decision of the provider and possibly in consultation with the PharmD. We had one incident where Streptococcus pneumoniae, even though it's less than 100,000 in this case, was detected, but it was not detected in the Unyvero system. We repeated this with residual BAL that was left over and still did not detect Streptococcus pneumoniae, and I cannot respond as to why or to explain why the pneumococcus was not detected by the Unyvero, but was detected in culture. And then I mentioned the Aggregatibacter cygnus, which is not part of the database in the Unyvero system. Now, Unyvero, once again, as you can see, did detect, by virtue of the Club pneumo and the Citrobacter, additional pathogens that were missed by culture. And once again, just for your edification, the green shading represents partial concordance, and then the off-panel organisms that we talked about earlier are not commonly regarded as etiological agents of pneumonia. If we look at the susceptibility testing and the gene markers in the Unyvero, here in the culture, the Enterobacter cloacae complex, we detected a CRE. It was enzymatic based through confirmation testing, and the Unyvero detected and reported as a KPC. Definitely carbamazepine resistant Enterobacteriaceae. These Staph aureus were MSSA. The Klebsiella pneumonia here, the CTXM gene was detected for this isolate and was confirmed in culture as an ESBL. So that's good concordance. Once again, one more combination of Staph aureus by both systems, both MSSA. Here we had a Staph aureus that was MRSA by culture. The MEK-A gene was detected by the Unyvero. Once again, MSSA by both methods. Pseudomonas aeruginosus, these were susceptible. And once again, there were concordance there, but in the Unyvero, it says no resistance detected. This was an MSA. Once again, MSSA, in other words, no MEK-A detected. Same for this particular situation. And of course, the Streptococcus pneumoniae and so forth both concurred here in that there aren't any gene markers really for the strep pneumo, but this particular pneumococcus was susceptible to the common agents that one would use for their management. And once again, Pseudomonas aeruginosa, susceptible, no resistant markers determined here as well. As you know, in Pseudomonas, other than AMP-C, there are porin channel-mediated resistance. There's efflux pumps, and of course, in the Unyvero, such genes are not part of the database. So overall, we had 37 negatives by culture, 37 negatives by Unyvero. I just wanted to point that out again. So there was excellent agreement with culture for both pathogen ID as well as detection of your gram-positive and your gram-negative resistant markers. And the only reason I wanted to show this was the fact that this particular one with the Enterobacter cloacae complex also had the Klebsiella oxytoca. Once again, I wanted to point out the additional targets that were detected by the Unyvero system in addition to the two that were concordant with that of culture. And this is just a summary of the previous slide. I think it's important. We report an ESBL in culture. It tells us that this is CTXM to consider an ESBL. This organism I had referred to as being resistant to cefepime and has trianem, and no resistance detected, once again, to emphasize most likely due to AMP-C mediated type of resistance. And once again, you can see for the Staph aureus and results of the MEK-A positive versus MEK-A negatives, overall good correlation. So in conclusion, the analytical performance of the Unyvero lower respiratory tract system demonstrated high correlation to conventional bacterial culture when testing bronchoalveolar lavage. And I do want to emphasize that other specimens can be tested on the Unyvero system, such as tracheal aspirates. We can do bronchial washings, but we wanted to focus specifically on BALs because they account for the majority of our volume of lower respiratory tract specimens when it comes to, if you will, invasive type procedures. The Unyvero system does allow for ruling in or ruling out of on-panel targets. For example, atypical or fastidious pathogens, specifically the pneumocystis and mycoplasma, much faster than culture. Of course, pneumocystis you cannot culture, but mycoplasma you can. And so this really is a benefit to allow for the opportunity for the antimicrobial stewardship in selecting appropriate therapy in real time. And we know that the culture results and susceptibilities usually require anywhere from 2 to 3 days, depending on the organism. So we're getting our results out much sooner, and Dr. Hoffmann will allude to the fact that the time that culture results versus the Unyvero results impacted on the management of the patient and antimicrobial stewardship. And of course, we demonstrated an excellent genotypic and phenotypic correlation of isolates. And the big thing and the nice thing about this is that it enables and provides 24/7 testing. And we are in the process of justifying its acquisition. And we have been approved recently for a 24/7 dedicated microbiology staff. And this will allow us to provide services around the clock, even with the addition of this particular instrumentation. I would also like to acknowledge a couple of individuals here before we conclude. I'd like to acknowledge Dr. Steve Sloan, who actually did the Unyvero testing, blinded, if you will, once again, to culture. Dr. Wes Hoffmann, who you will hear in a few moments, was the PharmD who managed the clinical impact and the antimicrobial stewardship, and 3 pulmonologists who were part of the selection process of patients, Dr. Rodrigo Cavalazzi, Dr. Alan Ramirez, and Dr. Mohammed Saad. And last but not least, Dr. Forrest Arnold, infectious diseases, who also was in the process of selecting patients for BALs and entry into the study. So with that, I will thank you and would be available for any questions once the webinar is completed. I will now turn the program over to Dr. Hoffmann.
Thank you, Dr. Snyder. My name is Wes Hoffmann, and I'm an infectious disease pharmacist at the University of Louisville Health System. Today I'll be going over the second portion of this discussion, which is the clinical utility of the Unyvero lower respiratory tract panel, specifically from an antimicrobial stewardship standpoint. So as probably many of us are familiar, antimicrobial stewardship, especially in an intensive care unit setting, is number one, critically important, and number two, an area of potentially very high impact. The point prevalence of antimicrobial use in the ICU can be as high as 70%, which was first identified in 1995, but since then has likely stayed the same or possibly even gotten worse in some of those settings. Unfortunately, only about 45% of patients had a culture confirmation of the etiologic organism. And with patients in the ICU, as many of us are familiar, much of the antimicrobial use involves very broad spectrum antibiotics, things like carbapenems, vancomycin, linezolid, etc. Now, there are some ways to combat this. Effective stewardship methods and education are going to be one key component to helping battle the overuse of antimicrobials in ICU settings. But that's likely going to be used in combination with rapid diagnostics to help reduce overall how many antibiotics are used, overall how many toxic medications are used, and to decrease the amount of antimicrobials that are used overall. Now, ideally, with the use of rapid diagnostics, you're going to want some technology that has favorable sensitivities, specificity, and a negative predictive value to help make clinical decisions that are appropriate in the setting of critically ill patients. Despite identification of organisms via culture, rapid diagnostics can help decrease unnecessary broad spectrum use by getting you answers to potential mechanisms of resistance that would otherwise take potentially anywhere from 2 to 4 days until you get final susceptibility results, which is how long patients may often have to remain on broad spectrum antimicrobials before you can de-escalate to what may end up being a pan-susceptible organism. The other factor that comes into play here is per some IDSA guidelines, especially in the setting of pneumonia, combination therapy is often recommended in things like ventilator-associated pneumonia, oftentimes with aminoglycosides, given the high amount of resistance that can be found in ICUs. If you have to continue these combination therapies that are exceptionally broad spectrum, that increases the risk of adverse events and potential development of resistance later on. Now, the study that we did here with Unyvero, which to our knowledge is the first time that this has been done prospectively, was to take patients who were in ICU care who had a bronchoalveolar lavage done for diagnostic purposes, and it was evaluated with the Unyvero lower respiratory tract panel. This was done in addition to standard culture and susceptibility testing, which is always going to be a component done in conjunction with the Unyvero. Now, the results from the Unyvero were communicated to the primary team in this study when the results were available, and they were also reported to the infectious disease pharmacist, who's a member of the antimicrobial stewardship team. Now, we had 15 patients included in the clinical evaluation of this study, and as we can note here, de-escalation occurred in 33% of patients. Now, this was sometimes just de-escalation of MRSA therapy, sometimes just de-escalation of anti-pseudomonal therapy, and at times it was a combination of de-escalating from MRSA and anti-pseudomonal therapy. 20% of patients ended up having an escalation occur, one of these cases involving a carbapenemase producer, another case involving ESBL. Times when we were not adequately covering what the patient ended up having identified and subsequently confirmed in culture. Overall, a little bit over half of patients had some change made with the Unyvero lower respiratory tract panel, and oftentimes this was done faster than conventional methods. So the results that were reported, as I mentioned earlier, were reported to the infectious disease pharmacist, who then discussed with the team at the earliest potential opportunity the clinical ramifications of what those results demonstrated. And as I said earlier, the changes in therapy often occurred significantly faster than with conventional methods. So with our group of patients here, on average, it was a 21-hour faster change in therapy with Unyvero results. And this ranged anywhere from 0 hours, meaning we couldn't really make any change, all the way up to a little under 2 days sooner. Now, the little asterisk here is that this is compared to when susceptibilities resulted. Because this is not a head-to-head trial of doing some patients with the Unyvero panel and some patients without, there's no way we can really tell how soon they would have changed based on the susceptibilities reported. So this is perhaps a more conservative estimate, knowing full well that when susceptibilities are reported, oftentimes those are not seen for anywhere from an hour or two until potentially the next day. Now, when it comes to how to utilize Unyvero, this is kind of the method that we ended up following. And the first two are relatively easy to do for anybody involved. So escalation, obviously, if you identify something that you're currently not covering, say somebody is on ceftriaxone, you identify Pseudomonas, that's an easy use of the Unyvero to get them on appropriate therapy right away. If you have them on cefepime and you identify E. coli with a third-generation cephalosporin resistance gene, such as CTXM, which is identified by Unyvero, that would allow you to rapidly escalate someone to a carbapenem, and it's a fairly simple task to do. The other aspect, which is particularly easy to use, is the de-escalation of MRSA therapy. Now, largely in ICU settings, vancomycin or linezolid is really going to be utilized almost exclusively for MRSA. Given that the negative predictive value of Unyvero for Staph aureus is about 97%, and knowing that potentially half of those can be MSSA, that really gives you pretty solid indication that MRSA is not present and causing infection in this patient, at least from a respiratory standpoint. Now, of course, Unyvero doesn't take the place of something like positive blood cultures in the setting of endocarditis, but this is to be used for the clinical diagnosis of pneumonia. And by being able to de-escalate from MRSA therapy, there's really three major benefits to that. Number one, you're not using that drug. That's helping that patient. That's reducing the cost of the drug. It's mitigating the potential for adverse effects, such as vancomycin-induced nephrotoxicity, which is, of course, very well described. And lastly, it's also a reduction in cost of managing vancomycin in these settings. So that requires additional blood draws to get levels done, sometimes two if your institution is doing area under the curve monitoring and doing a two-level evaluation. It also saves pharmacist time, who otherwise have to manage both the levels and the calculations and the changes in doses of vancomycin. So those are the two easy ones, escalation overall and de-escalation of MRSA therapy. Where it gets to be a little bit trickier, but arguably sometimes more useful, is the de-escalation in gram-negative therapy. So a quick disclaimer with this is, of course, as I said, not as simple as de-escalating from MRSA therapy, because there are various gram-negative organisms and they can have significant differences in how they become resistant to antimicrobials. You really need to use Unyvero in conjunction with your local antibiogram and resistance data, as well as knowledge of basic resistance mechanisms in gram-negatives. Now, that being said, the use of a negative predictive value for species and resistance factors can still help you make a decision on what would be appropriate therapy for that patient. But knowledge of mechanisms of resistance and phenotypes are still critical to making those decisions. So when it comes to gram-negative therapy and potential de-escalation, negative results for any organism altogether can still help make a decision for you, or at least give you an idea of what direction to go. So with nothing being identified in a patient who clinically has pneumonia, generally speaking, that may give you an idea that you could potentially de-escalate from anti-pseudomonal therapy altogether. Not get rid of gram-negative therapy altogether, but at least de-escalate from anti-pseudomonal therapy. Now, of course, you have to take into consideration your hospital's common organisms. There is one particular organism that Unyvero does not identify, which is Enterobacter aerogenes, which is now Klebsiella aerogenes. But generally speaking, for what mostly you're going to see in an ICU, this can be very helpful by knowing that a common gram-negative is not causing infection. The other consideration to take into account is that some patients have very obviously patient-specific factors that accompany them. So patients with cystic fibrosis or severe bronchiectasis may sometimes harbor something like Burkholderia, which is not identified by Unyvero, But if Unyvero is negative and that patient has a history of Burkholderia, you're probably not going to de-escalate in that setting. That's overall probably a significant minority of patients that will have something like this going on in the ICU, so this can still be useful. You just always have to keep those patient-specific factors in mind. The other thing to keep in mind, especially for stewardship programs, is that willingness to de-escalate may depend on the patient's clinical status and the comfort level of the primary team. I'm sure we're all familiar with patients who are very critically ill and possibly on 4 pressors, and quite honestly, fear drives a lot of antimicrobial use, especially in ICUs. Primary teams may not necessarily want to rock the boat if a patient has improved ever so slightly on combination therapy, even though logically they may trust the results of this. It may be difficult to, in real time, de-escalate drastically in this setting. They may want to wait till the next day, and that's understandable. I'm sure many of us have been burned by missing an organism from time to time. But with that being said, the very nice thing about Unyvero is that Pseudomonas and Acinetobacter both have a negative predictive value with Unyvero of 98%. Oftentimes, it is unlikely that anti-pseudomonal therapy will help in those settings, particularly extremely broad spectrum agents like carbapenems. Now, when identifying specific organisms, such as E. coli, for example, once again, knowledge of your local resistance factors are going to be key. So in this kind of algorithmic box here, E. coli is identified. As we know from an earlier slide and the discussion with Dr. Snyder, resistance genes are going to be identified by Unyvero to the extent of what that panel covers. So CTXM is an example of that, and that's largely related to cephalosporin resistance and ESBL activity in the setting of E. coli. Luckily, E. coli usually becomes an ESBL by using the CTXM gene. That is the most common mechanism to have an ESBL phenotype. So if that gene is identified, it allows you to escalate quickly to meropen if that patient was not already on it. However, if that gene is not identified, it's not to say that there's no chance of ESBL, but it's a very low chance, especially if you know your hospital antibiogram particularly well. In that setting, generally speaking, ceftriaxone is going to be active. There are some rare cases where plasmid-mediated AMP-C beta-lactamases can be present in E. coli, but oftentimes that represents 1% or less of isolates. So oftentimes you can de-escalate off of anti-pseudomonal therapy to something like ceftriaxone if E. coli is identified. So that is one of the mechanisms by which Unyvero can be useful, and you don't have to wait for final phenotypic susceptibility tests to make an adjustment. In the next example, let's take something like Pseudomonas aeruginosa being identified. As most of us know, Pseudomonas has multiple resistance mechanisms that are extremely diverse and are also not recognized by Unyvero. These include things like AMP-C derepression, which can lead to resistance with cefepime, piptazo, and ceftazidime. Can also have porn mutations, which can lead to resistance with carbapenems. So in a setting like this, using Unyvero plus your local antibiogram data and knowledge of these resistance mechanisms can still help guide appropriate therapy for your Pseudomonas, even without telling you what the resistance factors are. For example, IDSA guidelines suggest doing combination therapy for HAP and VAP for critically ill patients because of the likelihood of significant resistance in some of these gram-negative organisms. If you've identified Pseudomonas, that makes you feel far more comfortable about continuing that combination therapy, even though it involves an agent that is potentially more toxic, like an aminoglycoside, knowing that you're actually potentially getting some benefit out of it. Compared to something like E. coli without any resistance factors, you may feel far more comfortable just doing one agent rather than combining with an aminoglycoside, because you know that a beta-lactam, especially if you're going broad with meropenem, is highly unlikely to miss any of those organisms. So the utilization of Unyvero plus your knowledge of gram-negative resistance, specifically in Pseudomonas, can still help guide appropriate therapy, even if it remains broad in the setting of combination therapy. Now that is largely the three methods by which we utilized Unyvero, and hopefully helpful in some ways that you can utilize this technology to help de-escalate or escalate when appropriate. As we found in this evaluation, the Unyvero lower respiratory tract panel can provide rapid and actionable results, particularly if used in conjunction with an active antimicrobial stewardship program. The negative predictive values of Unyvero can be extremely useful in reducing excessive exposure to unnecessary antimicrobials, particularly MRSA therapy and at times carbapenem and anti-pseudomonal therapy. Now, with all that being said, while Unyvero can be useful on its own, knowledge of resistance mechanisms of some of these key organisms and knowledge of your local resistance rates are likely going to be necessary in combination with Unyvero to make the best possible decisions for patients that you're seeing. While Unyvero, as we said, can be useful on its own, really the best way to get the most out of it is to use this combination approach to help guide therapy and avoid any adverse effects. Thank you very much for listening to this. We will move on to the Q&A portion of this series. Please, if anybody has any questions, let us know, and we would be happy to discuss further. Thank you.
Thank you, Dr. Snyder and Dr. Hoffmann, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So let's get started. Dr. Snyder, it looks like our first question is for you. Your data shows very good correlation between the Unyvero and quantitative culture ID. So it looks like the qualitative reporting scheme or call logic of the Unyvero system works well and no reporting bins are needed?
That is correct. Once again, the good correlation is such that how we report in the laboratory from the standard practice versus what we're reporting from the Unyvero, we're confident because of the good correlation that we are generating data that is very useful to our provider as well as the PharmD.
Great. Thank you, Dr. Snyder. Moving on to our next question. Dr. Hoffmann, I have one for you here, and this looks to be a two-part question. What are the limitations of this panel? And the second part is, and are the limitations specific to this panel or general limitations?
Yes, so the limitations of the panel are, obviously the panel only covers what it covers. So, you know, there are times, as we discussed with the Burkholderia example, that, you know, you're just going to miss some organisms, and so knowing patient-specific histories is always important. The other limitation, which I think is worth repeating, but generally fairly obvious, that this is limited to respiratory tract infections. So, you know, especially in critically ill patients, there can be a lot of stuff going on. So, you know, somebody clinically appears infected and it's likely pneumonia, but there's maybe some concern for intra-abdominal source of infection as well. That's going to obviously be a limitation that even if you utilized Unyvero to try to identify some pathogen from the respiratory tract, if there's still a concern for some other source of infection somewhere else, that may not allow you to utilize that as much, unless, of course, you identified some escalation opportunity from the respiratory tract. But de-escalation may be a little bit harder in that standpoint.
Great. Thank you, Dr. Hoffmann. And our next question is, how useful is semi-quantification in pneumonia panels?
I'll take it, and then if Dr. Hoffmann has any comments, fine. I have very little confidence in the semi-quantitative pneumonia panels. It's from our perspective and experience and talking to others, it's very difficult to really assess the true clinical relevance of those quantitative data that are coming off the pneumonia panels. They use an algorithm-based system, and once again, we personally do not use the pneumonia panels, but talking to others that do and following the literature, there are questionable areas as to the clinical relevance and overall interpretation and correlation with standard culture, if you will. So I think there's room for improvement on these pneumonia panels, and that's why we do these studies, to cite areas of limitations that require further investigation.
Great. Thank you so much, Dr. Snyder. So we have time for a few more questions. I do want to remind our audience that those questions we are unable to answer today and those that come in during the on-demand period will be addressed by our speakers via the contact information that you provided at the time of registration. And so it looks like our final question is going to be for Dr. Snyder. You mentioned that there was educational opportunity for your lab staff in reporting respiratory culture results, and what is the pathogen that should be reported and what is not a respiratory pathogen. How do you go about this type of education in your lab?
A couple of ways. With regards to the study that we conducted, I would get the results and then I would compare those to what the laboratory were generating. And when I saw discordant results, I would go to the technologist that was responsible for generating the result, and we would have a discussion as to why this organism was identified when we know that it's not a customary agent of pneumonia. This was an educational opportunity for the technologists, and we're fortunate to have probably 30% of our younger technologists on board who are learning every day like the rest of us as we do. The other mechanism is through our daily laboratory rounds, and we use the Keystra, PLA, and there is a box on the dashboard that the techs reading cultures and so forth can put a question in under my name. So in addition to coming by every day for lab rounds, we also look for those questions, and those are educational opportunities. So it's just a matter of sharing with the staff the nature and overall clinical clinical association of these organisms as they relate, in this case, to pneumonia or whatever other infection. So once again, it depends on the specimen type. But as far as the study was concerned, those discordant isolates that we had identified in the clinical laboratory, but not part of the Unyvero database, this was an opportunity to share with the technologists why these organisms did not require full workup. And once again, that's purely educational, and we see consistency more and more each day with regards to what we've learned previously. And of course, lab rounds is the opportunity to see not only unique situations, but to answer questions for those techs that are assessing the cultures.
Thank you so much, Dr. Snyder. Before we go, I would like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by our speakers via the contact information that you provided at the time of registration. We would also like to once again thank Dr. Snyder and Dr. Hoffmann for their time today and for their important research. We'd also like to thank LabRoots and our sponsor, OpGen, for underwriting today's educational webcast. You can view the webinar on demand. LabRoots will alert you via email when it's available for replay. That's all for now. Thank you for joining us. And until next time, bye-bye, everyone.